that hall because that is the most important concept in neurology. Now, for those of you who have experienced my classes before, I think almost everybody here should have. For the step one, I predominantly use first aid to teach. But the step two is a little bit different. It's a little bit different because you need a lot of information for step two. So it has to be an interplay of a lot of things. So I basically don't use FA for step two teaching, basically. Um, I usually have my own written notes, which I will not be using in this class. I will just use a guideline in this class to teach, basically. So let's keep moving. Now, I'll share my whiteboard. One second, please. I'll share my whiteboard and then we can have this conversation moving. So let me open my whiteboard and share my screen. So the lecture is going to be at the whiteboard almost all through today. So when we talk about stroke at the level of step two, there are some things you will need to know. Now, this is the guideline I'll have to teach today. We're going to look at the broad types of stroke, which is the ischemic and the hemorrhagic stroke. Then we're going to understand the arterial tentorial stroke before we can now hit the management of stroke. So we're going to be playing with a lot of concepts. We're going to be bringing half and halves together. Then we're going to merge this half and half together to actually make sense. Now, the things you will likely be tested if you look at your UWorld and you look at your MBME 10 to 14 when it comes to neurology and stroke, you'll be tested on diagnosis. Now, diagnosis will entail what part of the brain is affected. So, what part of the brain is affected? You get a patient and they give you the patient presentation. They want you to be able to identify with this presentation this patient have, which area of this patient brain is likely affected. Now, on the other hand, they also want you to know what artery is affected. If somebody has affectation of, let me say, the frontal lobe, or the person have affectation of the temporal lobe, if it's the middle frontal lobe, I know that it is the ACA that is affected. If it's the temporal lobe, it's the middle cerebral artery that is affected. So you have to know what part of the brain. You also need to know what artery is affected. Then when you've been able to sort out this, you should now be able to know the stepwise management. So there's a lot of work to do here. The work here is not so much. So let's get this business moving. So let's start with the two types of strokes. Generally, there are two basic types of stroke, which everybody here knows. I'm not going to dwell so much in it. There's the ischemic stroke. When you talk about ischemia, it's due to shortage of blood flow to a particular organ. So you have an ischemic infarct. Then you have hemorrhagic stroke, which is when you have hemorrhage in that part of the brain. The ischemic stroke is usually the most significant because this one is the most common you see a lot of people have. Now, if that is understood, let us look at how you will approach an arterial tentorial stroke. Now, this is the arterial tentorial stroke. At the end of this class, you should be able to follow me on a lot of things. So what you need to understand is this. There are several things you will need to understand for you to be able to look at a clinical vignette and tell yourself, this patient in front of me, I'm very much confident that this patient has a left anterior cerebellar artery stroke. There are several things you will have to consider for you to be able to tell yourself in that 90 seconds that I am very confident that this patient in front of me has a stroke that is coming from the lateral medulla. And those are the things we're going to be playing with right now. So for you to be able to understand the arterial tentorial stroke, that is be able to tell what part of the brain this stroke is affecting and the artery that is involved, you will need to understand your cranial nerves. You will need to understand your cerebral hemisphere. You will need to understand your circle of Willis, and then you will need to understand your brain stem. The cranial nerves you will need to understand is cranial nerve 3 to cranial nerve 12. So we have started. If you observe how I am doing this, it's not like the way I tutor you in step 1. At this point, I'm already assuming you have a baseline knowledge because for you to have passed the step 1 exam, you have knowledge already. My job is to build on that knowledge and point you in the right direction. It's not teaching you what you already know all over again. Now, let's start from the cranial nerves. We know the cranial nerves already, but I'm just going to summarize the cranial nerves again in terms of their function. So let's start with cranial nerve 3 to 12. Please, all of these things I'm saying, be following me on them and keep this information because at the end of the day, we're going to play around this information. That is where we have combination of the above 4. We're going to combine it and you're going to see how the combination of those 4 things will be able to sort out any question on where is this stroke located or which artery is affected. Now, when we look at our cranial nerve 3 to 12, I took out 1 and 2. Cranial nerve 3 is the one you call your oculomotor nerve, if you remember. Now, your oculomotor nerve, what is it responsible for doing? If you look at the muscles that you find in the eyes, if this is the eye, so let's just settle 3 cranial nerve here. If this is the eye, let's say this is the nose here. There are 6 ocular muscles, extraocular muscles that control the movement of the eyes. For example, if you want to look up, look down, look sideways, there are muscles that moves your eyes in those directions, basically. And that is exactly what we're going to be hitting now. There are cranial nerve that controls those movements. Now, there are 6 muscles, basically. There's a muscle here you call the inferior rectus. You also have the superior rectus. So this is already two. Now there's a medial rectus and there's a lateral rectus. In addition to this, you also have the inferior oblique and you have the superior oblique. Now, the important thing I want you to know is that cranial nerve 3, out of these six muscles, cranial nerve 3 controls four of them. And there's a simple way I want you to remember those four. Just know that it does all the rectus except for the lateral rectus. If we look at it, we have four rectus. So if it does all the rectus apart from the lateral rectus, what it means is that it does three rectus, 1, 2, and 3. So it does the superior rectus, inferior rectus, and middle rectus. The other thing it does is the inferior oblique. So these are the four your cranial nerve 3 controls. If the cranial nerve 3 is damaged, the person will have drooling of the eyes and the eyes will be popped out. That is ptosis. The person will have ptosis and drooling of the eye. That is what a cranial nerve 3 palsy will give you. Now, this one in blue is your cranial nerve 4. Your cranial nerve 4 is the one you call your trochlear nerve. That one only supplies one muscles of eye movement. That is this guy here, superior oblique. If somebody has the cranial nerve 4 problem, they will have diplopia. That is one of the problems they will have. Then you will see that eye rolling upward, basically. Then the third cranial nerve, you need to know that also supplies muscles of extraocular movement is cranial nerve 6. Please, I know why I'm taking my time to go in this direction because we need this interplay at the end of the day. Now, cranial nerve 6 will supply the lateral rectus muscle. Of course, the lateral rectus muscle will move the eye laterally, meaning away from the nose. If you are by my side and I want to look at you without moving my head, it is my lateral rectus I will use to move my eyes to look at you. So if there is a problem with the adducens nerve, which is cranial nerve 6, the lateral rectus muscles will not work again. So the person will have a defect in lateral gaze or horizontal gaze. Anyone you want to talk about it. So defects in lateral gaze or horizontal gaze. So of the 10 cranial nerves we want to talk about, we have settled 3. Remember, you need to know cranial nerve 3 to 10 to 12 rather, for you to be able to understand the arterial tentorial stroke. This is me taking you a little bit to your step 1. Now we have done 3 of these cranial nerve. Let's keep moving. So the next one we should look at is the cranial nerve 5 in summary. Now cranial nerve 5 is what you call your trigeminal nerve. If you remember, your trigeminal nerve will have 3 different branches, the V1, the V2, the V3, which corresponds to the ophthalmic branch, the maxillary branch, and then the mandibular branch. In terms of function, you need to understand that it is responsible for providing motor supply to muscles of mastication. That is the muscles that help you to chew. It is your trigeminal nerve that supplies it. Then it also supplies sensation to the face as well as the anterior two-thirds of the tongue. So muscles of mastication It supplies it. It supplies sensation to your face. So if I say this person cannot feel on the left side of his face, it means the trigeminal nerve is affected because it's the trigeminal nerve that gives sensation to the face. It also gives somatosensory sensation to the tongue, the anterior to tongue. Now, somatosensory sensation is different from sensation of taste. Somatosensory sensation is the like of pain, temperature. For example, if I give you a hot food for you to eat, when that food gets into your mouth and it burns you, you will throw it away. That time where you're feeling that pain from the burn of that food, it is your trigeminal nerve that is picking it out. If I ask you, this food you threw away because it was very hot, is it sweet or is it salty? You will tell me you don't know. The only thing you know was that it was very hot. That's why you spit it out. So please know that somatosensory sensation is different from thirst. Trigeminal does somatosensory sensation. Now, when we move to look at cranial nerve 7, we have already done 6, which is adenosine. I want to compare 5 and 7 because a lot of people confuse them. 7 is this one I'm going to write in red. 7 is your facial nerve, if you get to look at it. Now, sensation to the face is by trigeminal nerve, but sensation to muscles of facial expression is by the facial nerve. So if you smile or you decide to frown, it is the facial nerve that is supplying those muscles that is causing you to frown or to smile, because smiling and frowning are all facial expression. But if I touch your face for sensation, it is not trigeminal. In addition to this, the facial nerve supplies sensation of taste to the anterior two-thirds of the tongue. So you can do taste, not somatosensory, to anterior two-third of the tongue. We have a long way we're going, but we're tying it in. We'll definitely get there. Then in addition to this, it will also supply, or it is responsible for lacrimation, that is tears production. It is responsible for salivation, especially from the S&S salivary gland, that is submandibular sublingual. So I'll put lacrimation and salivation. You need to be taking note of these things I'm saying, because we're going to use this thing at the end. So we have done cranial nerve 3, 4, 5, 6, 7. So we've done 5 out of the 10. We have another 5 we need to look at. Now, the next one is cranial nerve 8, which is very simple. Cranial nerve 8 is what we call the vestibulocochlear nerve, CMV 8. So I call it VEST-COCH in abbreviation. The cranial nerve 8 has 2 basic functions. The vestibular part is responsible for balance. This is what helps you to maintain your balance. The cochlear part is what helps you for hearing. If this nerve is damaged, you cannot maintain normal balance and you will have a sensory neural hearing loss. The person cannot hear with that particular ear anymore. That is what the cranial nerve 8 does. Simple. The cranial nerve 9 is the one we're going to write in blue. Let me go to the next whiteboard and do that, because 9 and 10 are things I would like to compare. This is cranial nerve 9. Cranial nerve 9 does a lot of important things. And what are those things it does? Cranial nerve 9 helps for swallowing. So 9 and 10 causes the swallow reflex. Two of them combine together. Cranial nerve 9 causes salivation, but from the parotid gland. Remember, facial nerve is salivation from P and P, sublingual, submandibular. But glossopharyngeal, which is cranial nerve 9, is parotid. Then, very importantly, is responsible for supplying both tastes and somatosensory to the anterior, to the posterior one third of the tongue. So if you look at the posterior one third of the tongue, that is the area of the tongue that is behind the foramen cecum. Whether it is taste or whether it is temperature, pain, glossopharyngeal does both of them. You need to be following me because we're going to use every bit of this information at the end of the day. We'll interplay it and it will make sense. Now, when we talk about our cranial nerve 10, which is the valgus nerve, now for cranial nerve 10 does a lot of amazing things too. It is responsible too for swallowing. Remember, 9 and 10, two of them coordinate swallowing. Let me use black for this so that we can compare them. It is responsible for swallowing. Now, apart from swallowing, it does some important things. And those important things is it is the one responsible for cough reflex. It is also responsible for gag. So it does cough, it does gag, basically. Now, there are some less important functions you can see there. Chemoreceptor, baroreceptor. You can also do all those ones. But I'm just picking the very important function. Swallowing, cough, and gag are the main things it does. Yeah, it also carries the parasympathetic fibers. These are the important function of 9, of 10 rather. Now, when we do 11 and 12, 11 and 12, it's very easy. Cranial nerve 11 is the one we call the spinal accessory nerve. This is the one that supplies the sternocleidomastoid muscle and the trapezius muscle. These are muscles that are found in the neck and in the shoulder. If the cranial nerve 11 is damaged, the person cannot shrug their shoulder. The person cannot do that. If you've been in the neurology department, you'd have seen neurologists ask people, shrug your shoulders. If 11 is affected, that person can't do it. Then what does 12 do? Cranial nerve 12 supplies muscles of the tongue. Cranial nerve 7 and cranial nerve 5, including glossopharyngeal, all of them produce sensation to the tongue, not motor function. It is cranial nerve 12 now that does the motor function to the tongue. So if you want to move your tongue up and down, it is the cranial nerve 12 that does that because you need to activate the muscles in the tongue for you to move it up and down. So we have been able to talk about the important 10 cranial nerves. Cranial nerve 3 to cranial nerve 12. Please remember these things because we're going to be playing with it in less than no time. Now, let us do the cerebral hemisphere. When we do the cerebral hemisphere, we can do the brainstem I bring in the circle of Willis and we combine them and we play around. So when we do the cerebral hemisphere is like this. Now, in this cerebral hemisphere, you can have this part here. Let's call these green parts the frontal lobe. All these plates here. Let's say this is the frontal lobe. So this is frontal. Then let's say this is frontal. Let's say this this is temporal. The yellow part is temporal on both sides. This is temporal. And let's say the red is parietal. You know I'm going this mile. You just have to follow me and enjoy the class. This is parietal. And the blue one here, let's say this is occipital. This is the occipital lobe. So this is the cerebral hemisphere. The brain has different level. There's the cerebral hemisphere. There is cerebellum. There's the brain stem. You will need to know all of them because stroke can arise in every layer here. Now, one of the first thing I want you to understand is this cerebral hemisphere is divided into two, the left and the right. This is how it is divided equally. You have the left, you have the right. So let's say this is the left and let's say this is the right. What you need to know is that the left part of the brain supplies the right part of the body, and the right part supplies the left part of the body. So if somebody has a problem on the left side of the body, that person's problem is coming from the right side of the brain. If I see this weakness on the left side, I want to understand that it is the right side of the brain that supplies the left side of the body. Oh. So for this man's problem to be on the left side of the body, the problem is on the right side of the brain. That's the first thing you need to understand. Now, see the way the human being is arranged in the cerebral hemisphere. It is arranged like this. We call it homunculus. This is the person's leg. This is the leg. And let's assume this is the person's trunk. And let's assume this is the person's head, like this. So the person is arranged in an upside down manner in the brain. That is, the person's lower extremities is to the frontal lobe. This is the frontal lobe, if you remember. So the person's lower extremity is to the frontal lobe, while the person's upper extremity is to the other lobes. Now, what it simply means is this. I want you to take a good look. There are three main arteries that supply this cerebral hemisphere. There are three main arteries. Now, the first artery is the one that will supply this portion here that I'm enclosing in black. See this portion I'm enclosing in black. So it supplies the medial frontal lobe. That artery is what we call the anterior cerebellar artery, ACA. Now, if you follow this human being I drew in an upside manner, if your ACA is affected, what part of the human being will be affected? The lower extremities. So if I see a patient and this patient is having weakness of only the lower extremities, I can confidently tell you that that patient is having an anterior cerebellar, an anterior cerebral artery stroke. We're not tying things together. Just by understanding that the anterior cerebral artery supplies this medial frontal lobe and the lower extremity lies in the medial frontal lobe. Once I see that weakness is in the lower extremity, the upper extremity is spared, I will quickly tie it in. The other thing I'll have to ask myself is looking at this contralateral rule. I will now have to ask myself, is this person weakness on the left or on the right? If I discover this person's weakness is on the right, I will tell myself that this person have a problem with the left anterior cerebral artery. Straight up. Now, if this person is having a problem, this is where your middle cerebral artery comes in. So this area here, all of this area like this that I'm marking in red, all of them, all this area here is supplied by the middle cerebral artery. So if this person is having weakness that has to do with maybe the face, the upper extremities, which is the hands, and the lower extremity is spared, this person is having a problem with the middle cerebral artery. The question now I'll be asking is, where is this weakness more? Is he on the left? Is he on the right? That is the next thing I'll be asking basically. And from there, I can tell you this is which of the middle cerebral artery that is affected. Now, there's one more thing I will have to tie before we move. The posterior cerebral artery, of course, enters here. This is the PCA. Now, let me tie some important things. You see, the part of the brain, one part of your brain must be dominant. The other one will be non-dominant. The way God created the human body is that one of them have to take control over the other one, because two of them cannot be dragging for dominance. If you're right-handed, which most persons are, the dominant part of your brain is left. If you are left-handed, which a few people are, the dominant part of your brain is right. Basically. Now, if that is understood, let's now add some things. How will you know that this person's problem, let's assume they brought in a patient for you and the patient is unconscious and you've not taken any history from the patient, you can't get a good history from the patient to know if the patient is right or left-handed. How will you be able to know that the stroke is affecting the dominant area or the non-dominant area? Now, there are some things you find in the dominant area you don't find anywhere else. What are these things? Let's assume this is the dominant area. This man is right-handed, so the left is the dominant. In the frontal lobe, you see what we call the Broca speech area here. In the temporal lobe, you will see the Wernicke speech area. So whenever you see anybody has a stroke and that person has aphasia, that is inability to talk, whether it is expressive aphasia or whether it is the receptive aphasia. If you damage this vocal speech area, the person will not be able to talk. If you give them a biro, they can write. You're asking them a question, they know what they want to say, but they just cannot write it down. If it is the Wernicke speech area that is affected, the person is talking, but everything he's saying is not making sense. We call that one the word salad. So whichever one that is affected, whether the person is not making sense or the person cannot talk, automatically know that that person is having affectation of the dominant lobe. And if you look very carefully, what artery supplies this region, look at both the Broca speech area and the Wernicke speech area, all of them fell in the area of this red arrow, which is supplied by the middle cerebral artery. Straight up. Now, your visual cortex will be here. This is where your visual cortex will be. So anything that affects the posterior cerebral artery, the person will have loss of vision in one side of the eye. If it happens to the right posterior cerebral artery, remember, right supplies left. The person will have visual loss on the left side of the eye. This is the cerebral hemisphere. And this is how you need to understand the areas of the cerebral hemisphere. Now, let's talk about the brain stem. I will tie in the circle of Willis. Will now play around with all the things we have talked about: the cranial nerve, the cerebral hemisphere, the brain stem, circle of Willis. We match the four of them together and play around questions. Now, when you look at the brain stem is completely different from the cerebral hemisphere. Your brain has different levels. As you move from top to bottom, you find out that there are different levels of the brain, and each of them have their own function, basically. Now, when we talk about the brainstem has three different people together. It has what we call the midbrain, it has the pons, and then it has the medulla, basically. These are the three things that makes up the brainstem. If you don't know brainstem, your neurology is weak, because the brainstem is like the heartbeat of neurology. This is where you have a lot of playing around. So this is the midbrain, call it MB. This is the pons. This is the medulla, call it MD. This one is M and B. Now, if this is understood, let's add a lot of context to this. Let's play around this. Let's play around this and um let's see what and what we could be able to get from this. Now, you need to understand how structures are arranged in the midbrain. It is going to be super important. You will need to know how these structures in the midbrain are arranged. It is super, super important. Now, There are three things I want you to use to mark the territories of the brain stems. I want you to use that cranial nerves we talked about. I want you to use the M structures. I will explain. And I want you to use the S structures. I will explain. Now, what you need to understand is this. We have 12 cranial nerves. And of these 12 cranial nerves we have, there is a way they are arranged in the brainstem so that when a person have a particular problem with a particular cranial nerve, you can tell for sure that this person's problem is coming from this part of the brain, just looking at how the cranial nerve is arranged in the brainstem. So of that 12 cranial nerves you have, only two of them is seen outside of the brainstem. So only two is outside of your brainstem. The rest 10 dwells in the brainstem. So if the rest 10 dwells in the brainstem, how are they arranged? Remember, the first two is out. That is cranial nerve 1 and 2. Those ones is seen in the cerebral hemisphere. If 1 and 2 is out, what do we have left? What we have left is 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now, two of them is, okay, let's say two of them is in the midbrain, of course. Then the other four is in the pons. The other four is in the medulla. So the rule they use or the mnemonic they use is 4 of the cranial nerve is above the pons. 4 is in the pons. The other 4 is in the medulla, that is below the pons. So look at the mnemonics to help you remember. 4 cranial nerve above the pons, 4 in the pons, and 4 below the pons. That should make sense. So you just know that the first cranial nerve 4, that is 1, 2, 3, 4, is above the pons. The next 4 sets of cranial nerve, which is 5, 6, 7, 8, is in the pons. And the next 4, which is 9, 10, 11, 12, is below the pons. So in the pons now is to be cranial nerve 5 to 8 if you follow it. In the medulla now will be 9 to 12. Remember, there are 12 cranial nerve. We have shared it into 4. We have shared it into 3. 4, 4, 4. The first 4 is above the pons, meaning 1 to 4 is above the pons. The next 4 is in the pons, and the other last 4 is below the pons. So if number 1 to 4 is above the pons, it simply means 5 to 8 will be in the pons and 9 to 12 will be below the pons, which is in the medulla. Of those 4 that is above the pons, 2 of them is in the cerebral hemisphere and only 2 is in the midbrain, which is 3 and 4. So you see that 10 of them are now in the brainstem, from 3 to 12 are in the brainstem, but they occupy different places. This is the first thing we're going to talk about. Now, let's elaborate this thing more. If you've gotten it up to this point, remember, this is not a step 1 class. I assume if you pass, for you to be in this class, you have already passed your step 1. And if you pass your step 1, you have knowledge. If you pass the right way, you have knowledge. And this is where you have to apply the knowledge you have, because we're not teaching you from beginning. Now, if you understand that you have 2 cranial nerves here, You have four here, and you have the last four here. There is a way these cranial nerves are arranged in the brainstem. Now, how are they arranged? They are arranged in such a way that all the cranial nerves that can divide 12 and there will not be any remnant will be kept in the middle. So any number that can divide 12 and remnant will not be there will be in the middle. So if you look at 12, 3 and 4 can divide 12. 3 can do that, 4 can do that. So in the midbrain, you have two cranial nerves, 3 and 4. Two of them are in the midline, 3 and 4. Now, when you come to the pons, you have four cranial nerves. There are 5, 6, 7, 8. Of those four cranial nerves, is only one of them that can divide 12 and no remnant, which is 6. So 6 will be in the middle. The other ones will be on the side. So let's say 5, 7, and 8. You see how they are on the side? 5, 7, 8. So this is the lateral pons, and 6 is occupying the middle pons. That is where 6 is, because it can divide 12 without a remnant. Now, if we come to the medulla, you have 9, 10, 11, 12 in the medulla. The only thing that can divide 12 without a remnant is 12. So in this medulla, 12 will occupy the midline, while the other 9, 10, 11 will occupy the sides. You should be getting the gist at this point, meaning this is the lateral medulla where you have the 9, the 10, and the 11, and 12 occupies the middle medulla. Now, this is how you use this cranial nerve I told you about earlier to be able to pick out what part of the brain the stroke is affecting. For example, if they tell me in a clinical vignette in the like of you all that this person presented with loss of sensation to the face, and the person also have absent tearing, that is lacrimation, and dryness of the mouth, salivation is also affected, and an impaired taste to the anterior two-thirds of the tongue, maybe a form of sensory neural hearing loss. I can comfortably tell you that that person has a stroke that is affecting the lateral pons. How did I know? Loss of sensation to the face is trigeminal nerve, cranial nerve 5. That lack of tearing is lacrimation. Lack of saliva production and the taste are all carried out by cranial nerve 7. The hearing is vestibulocochlear, and all of them are in the lateral part of the pons. I can comfortably tell you that this person have a lateral pontine lesion. What if they tell me that, oh, the person is unable to move the eyes laterally? I know that if you cannot move your eyes laterally, the lateral rectus muscle is affected. The cranial nerve 6 supplies the lateral rectus muscle. The cranial nerve 6 is located in the middle pons. So this person is having a middle pontine stroke by just picking out the cranial nerve that is affected. You can do the same thing for the medulla. If you tell me this person have a problem with swallowing, the person cannot gag and cough reflex is weak, I know that what is affected is cranial nerve 9 and 10. 9 and 10 is in the lateral medulla. I know that this person's stroke is a lateral medullary stroke. Take it to the moon. This is how to play around it with the cranial nerve. You see that cranial nerve we talked about early. You see where we're now bringing it. This is how to pick out the areas of your brainstem that is affected, looking at the cranial nerve. Now, let us look at the M structures. The M structures are those things that have M to their name. And there are two M structures we need to look at for the media lemnisci. I just call it media lemni, just to abbreviate. And then the motor function, which is carried by the corticospinal tract, motor fiber. Those are the M structures. What you need to understand is this: the dorsal colon and the medial lemnisci is the same thing. It's just that when one moves from one region to the other, the name changes. When one moves from one region to the other, it changes, but it is the same thing, exactly the same thing. I just want you to imagine a Nigerian that has stayed in the US for a long time and has gotten a US passport. The person is now a US citizen. If that person is traveling back to Nigeria, the person will use the Nigerian passport and be on the normal citizen line in Nigeria. When a person is going to the US, the person will use the US passport and also be on the citizen line in the US. Now, the thing is this: it is the same person, oh, it is exactly the same person, but it's just that when the person changes location, the person's identity change, but it is exactly the same person. That's exactly what happens here. In the spinal cord, it is called the dorsal colon, but when it hits above the spinal cord, that is into the brain, the name changes to medial lemnisci. So the same way the dorsal column carry proprioception and vibration, that is the way the dorsal column still carries proprioception and vibration. Then we all know now that the motor fibers is carried by the corticospinal tract. So everything that has M to their name is arranged in the middle. So you will have the medial lemnisci in the middle medulla, and you will also have the corticospinal tract that carries motor fiber in the middle medulla and in the middle pons. So you see them, anything that has M has to be in the middle. Corticospinal tract carries motor functions. That is why we put it as M, and medial lemnisci. So if I see somebody having a middle medullary lesion, for example, the person will have deviation of the tongue to one side. Why? Because cranial nerve 12 supplies motor function to the tongue. So that is why the tongue is going to be deviated to one side. Then in addition, the person is going to have muscle weakness because the corticospinal tract carries motor fiber. If it's affected, there will be muscle weakness. In addition to that, the person will have loss of proprioception and vibration sense because the medial lemnisci is affected. So whenever I see muscle weakness, loss of vibration and proprioception, I'm already biased that this is a middle stroke. The next thing I'm asking myself is which cranial nerve is involved so that I will tie it either to the pons or to the medulla. Now, the structures that have to do with S is on the lateral. This is the sympathetic chain, then the spinothalamic tract. So anything that has to do with S and S will be on the lateral. So sympathetic chain will be here, spinothalamic will be here, sympathetic chain will be here, spinothalamic will also be here. So if I see somebody that have affectation of, maybe the person have loss of temperature sensation, pain and temperature sensation on one side of the body, I know that is spinothalamic that is involved. And the person is having the like of Horner syndrome, which is telling me the sympathetic chain is also involved. I know that person is having a lateral stroke. The thing I'm going to be asking myself now is which of the cranial nerves is involved before I can now point it to either a lateral pointile lesion or a lateral medullary lesion. This is how to play around the brainstem. If you know this, we're good. The last thing we tie in is the circle of Willis, and then we move. Now, when we look at the circle of Willis, we're looking at the artery that supplies the brain. If we tie in the circle of Willis, we can now play around every other concept, and then we run from there. Now, we can either look at it in two phases. Either we look at it from top to bottom, or we look at it from bottom to top. But I want to use the letter which is bottom to top. Now, there are two arteries which are the vertebrate artery. This vertebrate artery run like this. They come from the subclavian, and the two of them will join together to give you the basilar artery. So this one now is, let's say, the right vertebra. This is the left vertebra. The left and the right vertebra join to give you the basilar artery. So this one here now is the basilar artery. Now this basilar artery will move and finally end as your posterior cerebral artery. This one here and this one here. So this is your posterior cerebral artery. But now I want you to understand this. Let me take out something. Let me take out this one. Now I want you to understand this. The vertebral artery give rise to two arteries, one on the outside, one on the inside. On the outside, it give rise to this artery here. Let me put it on this other side. It give rise to this blue artery here. The name of this blue artery is what we call the pica. The full meaning of the pica means posterior inferior cerebellar artery. Now, on the inside, it gives rise to this artery here that we call the anterior spinal artery. This one in red, we call it anterior spinal artery. I know I'm taking my time to draw all these things. Now, when you look above here, you have this other artery that comes from the basilar. This one is what we call the ICA, anterior inferior cerebellar artery. You have to follow me on this. Now, what you need to understand is this. This your anterior spinal artery, ASA, supplies the middle or the middle medulla. Call it middle med to abbreviate. The pica supplies the lateral medulla. If you watch, we're starting from bottom and we're moving to the top. The medulla is like the most bottom part of the brain. It is the one that connects to the spinal cord at the foramen magnum. That is the reason why pica will supply the lateral medulla and the anterior spinal artery will supply the middle medulla. Now, this ICA supplies the lateral pons. And the basilar artery here, this big one here is the basilar. The basilar artery supply the middle pons. It's in the middle now. So it should make sense. It will supply the middle pons. If you pass the medulla, the next thing you will get, if you're moving from bottom to top, once you pass the medulla, you hit the pons. That's why these ones supply the medulla. They are at the bottom. Once you move above it, the ICA will do the lateral pons because it's on the side. The basilar will do the middle pons. You already know what the posterior cerebral artery does. It supplies the occipital lobe. That is the one that when it's affected, the person have loss of vision in the contralateral eyes. Now, when we've already looked at the other arteries that supply the cerebral hemisphere, but just to bring them, we have the anterior cerebral artery here. This is anterior cerebral artery. Two of them are connected via the ACOM. This is like the anterior communicating artery. And you know where the anterior cerebral artery supplies now? It supplies the middle part of the frontal lobe, where you have the lower extremities represented. This one here, no, let's use purple for that. This one now is the middle cerebral artery. You know, the middle cerebral artery supplies a lot of region where the upper extremities is represented. It also supplies those places that have the like of the bronchial speech area and the rest. It supplies the parietal lobe, the temporal lobe, and part of the frontal lobe. It is connected to the posterior cerebral artery via the PCOM. That's the posterior communicating artery. This is your circle of Willis. Now let's play around with everything we have talked about. So if I see a patient, for example, you have all the information now. So let's play. If I see a patient, for example, and this patient presented with sudden onset weakness, and this weakness is affecting more of the upper extremities. The lower extremities is fine. And in addition, this patient is having difficulty in communicating clearly. That is aphasia. And I'm asked, which of the following artery is likely affected? And I'm seeing, let's assume this is a right-handed man, and I'm seeing different types of artery, but in that option, I'm seeing the left middle cerebral artery, and I'm seeing the right middle cerebral artery. I'm going to go for the left middle cerebral artery. Reason being that this man has problem in the upper extremities. I'm already sure that he's having a problem with the MCA. But telling me it's affecting the speech areas. I know the speech areas is in the dominant lobe, which for people who are right-handed is usually the left. That settles that query. Now, imagine that I see a patient that have loss of sensation to the right side of the face. He also have ptosis and anhidrosis, which are component of Turner syndrome. And he has loss of pain and temperature sensation to the left side of the body. They are asking me which area of the brain is this person's lesion coming from. I take it again, listen carefully. Now we have this man that has loss of sensation to the right side of his face. He has anhidrosis and ptosis of the eyes. This same man has loss of pain and temperature sensation to the left side of the body. And they're asking me, this man's problem is coming from which area of the brain? This man's problem is coming from the right lateral pons. If you ask me, the artery that is involved is the right anterior inferior cerebellar artery. Why did I take the right lateral pons? Now, the first rule you should know is that cranial nerve problem is ipsilateral in most cases. So anywhere you see the cranial nerve problem is where the lesion is. It is cerebellar problems that are mainly contralateral. So this man's cranial nerve problem is on the right side of the face. That is why I'm going to take the right lateral pons. Why am I even choosing pons? Because it's cranial nerve 5 that supplies facial sensation. And cranial nerve 5 is seen in the lateral pons. But I was able to localize it to the right because the facial nerve problem is on the trigeminal nerve problem rather is on the right. And you see his loss of pain and temperature sensation is contralateral. That should make sense. That one is not a cranial nerve problem. That is why it has to be on the other side of the body. You can apply this concept to pick out stroke from any single location. Whether that stroke is coming from the cerebral hemisphere, because the commonest places you have stroke is in the cerebral hemisphere and in the brainstem, and those are the tricky areas. So you should always ask yourself, this patient that is before me, is there one single cranial nerve problem? If it is yes, ask yourself which of the cranial nerve. You should be able to sort the cranial nerve the way they are arranged in the pons, in the medulla, and in the midbrain. You should be able to say this is where this stroke is located. The next thing you ask yourself is which artery supplies this area. Once you have all those information, there's no way you're not going to pick out that answer. If it's also a higher center stroke, like the cerebral hemisphere, you'll be able to see it. Only the leg is affected, or just the upper extremities is affected, or you have affectation of those speech areas. Now, the final stroke I did not mention for you is what we call the lacunar stroke. For the lacunar stroke, there can be two main types of stroke. We could call it a pure motor stroke or pure sensory stroke. Lacunar strokes are strokes that they are not mixed. It will be hard for you to see them have motor and sensory disorder together. Lacuna will give you either a pure motor stroke, only motor function is affected, no sensory loss, or it will give you a pure sensory stroke, no single motor function is involved. If you see a lacunar stroke with pure sensory defects, that is coming from the thalamus. It's a thalamic lesion. So thalamus will give you a lacunar stroke that is purely sensory, no motor deficit. On the other hand, if this lacunar stroke is affecting the corticospinal tract, it will give you a complete or pure motor stroke. Straight up. Oh no. It will give you like a pure motor stroke, basically. That is the last one I want to mention. So at this point in time, we have been able to play around with the arterial tentorial stroke. Now, let us look at how you're going to manage stroke. This is the next thing we're going to look at. So let's look at the rapid assessment and management. We look at the initial radiologic and lab investigation. We look at administration of TPA. Now, like I told you, management of stroke requires you to know what is the best next thing I'm going to do at every single point in time. That is what is important. They brought in this patient. What am I going to do next? What is important? You have to do A before you do B. If they bring in your patient first, the first thing to do is to assess your patient. You have to do a quick assessment of your patient. That is the rapid assessment. In this rapid assessment, you have to do like a quick examination. You take a focus history at that point. You don't need to waste a lot of time because stroke is an emergency. Now, in the course of your history taking, if this patient have a glycocoma scale of less than 8, I have managed or I've been in team that have managed stroke patients with CGS of less than 8. For this type of patient, the next thing you have to do is you will have to intubate this patient because you will need to secure the airway. That is the reason why the initial assessment is important. You're looking at your patient, you're looking at your clinical veneer. If they tell you after initial assessment, the CGS was found to be like 7, what is the best next step? Intubate this patient straight up. Anybody, irrespective of what the problem is, once the CGS is less than 8, the person requires intubation directly. Of course, in the course of your initial assessment, you will do an SpO2. If the SpO2 is greater than 94, then if it's greater than 95, you're good. But if it is less than 94, if it's less than 94, you have to put the patient on oxygen. So these are the things you do immediately. Like this one, you don't require to go to the lab. It's what you do immediately you see the person. For example, you're seeing your patient, you're already putting a pulse oximetry in the person's finger. That one is reading immediately. You're already assessing this patient for speech, for motor, and you're also assessing the other components of CGS completely. You're able to say, oh, this guy is in 5, is in 8, is in this or that. Now, when you're done with this initial assessment, the next thing you will need to do is you have to do the initial radiologic and laboratory investigations. Once you suspect anybody has a stroke, the next thing to do is a CT scan. Not just a CT scan, a non-contrast CT scan. Please differentiate this. Non-contrast, meaning you don't use contrast. The reason is because non-contrast will be able to pick if the person has a hemorrhagic stroke or not. So after we have done that initial assessment, the next thing we're doing is a non-contrast CT scan of the head. We can also do some other investigations, like we're going to also look at the person's glucose level. We'll draw blood. We'll look at the glucose level. See that blood, we should be able to look at the lipid and others. But the glucose is something you must do. And I will tell you why when we move on. So you see, the first thing I did was to assess my patient. And from that assessment, I can now determine if my patient require an initial intervention or not. If my patient had any of the first two problems I said, like CGS is less than 8, my patient requires an intervention, my next best step will be that intervention. If my patient SpO2 was low, my next best step will also be put him on oxygen. But if everything is good or I have settled that, I quickly take blood, send my patient for non-contrast CT. Now, most of the times, patients that have ischemic stroke, we should be able to see that the non-contrast CT will be normal in the first 6 hours. It's going to give us a very normal study, classically. Now, once we have done that CT and we've taken that blood, the next question we need to ask ourselves is this. That is the third step here, which is the TPA administration. We need to ask ourselves, does this person qualify for TPA? What is TPA? Is the plasminogen activator, man, the thrombin plasminogen activator or the tissue plasminogen activator, whichever one. Now, let me give you a background of TPA small before we run. For those of you who did step one with me, you already sound on what TPA is. If you look at the final step of the coagulation cascade, the final step of the coagulation cascade is that you will need to take your you will need to have formation of your blood clots where you bring your fibrins together. The fibrinogen will have to go to your fibrins and you will bring everything together and form the fibrin meshwork. The TPA prevent formation of that final step. That is what it does, meaning it prevents clot formation. If you look at people that have ischemic stroke, it is a clot that is blocking the artery. So TPA will be able to dissolve that clot because that is what it does. It dissolves that clot formation. That final step of clot formation, it reverses it, it scatters it. But the problem is this: if you give somebody TPA, the person will have a higher chance of bleeding. That is where you now ask yourself, does this person qualify for TPA? Now, what are those things that will make this person qualify for TPA? The first thing is the time. When was this person brought to the hospital? If the person was brought to the hospital less than 4.5 hours to the onset of the stroke, less than 4.5 hours to the onset of the stroke, this person qualifies. Anything that is greater than 4.5 hours, this guy does not qualify for it. If it's greater than 4.5 hours, he didn't qualify for it. Now, there's something you need to know that is very important. My system is almost going down, so I'm trying to be very fast, which is not my normal pattern. There's something you need to know. Now, let's assume that you come in contact with a patient that you don't know when the stroke started. How do you manage that type of patient? For example, you're seeing a man, the wife is a nurse, the wife is on night duty. The husband and the wife ate dinner at 7 p.m. The wife is supposed to resume by 9 p.m. They ate dinner together at 7 p.m. They did the dishes together, and the wife drove off by 8 p.m. to the hospital. Coming back the next day by, let me say, 8 a.m., and saw the husband in that state and rushed the husband to the hospital. Now you're going to make an assumption that that particular stroke started 8 p.m. yesterday when the partner saw the patient last. That kind of patient does not qualify for TPA again. I hope you catch the analogy. In a case where you don't know the exact time the stroke started, you assume that the onset of the stroke started the last time they saw the person in a healthy state. And the last time that patient was seen in a healthy state was 8 p.m. when the wife was driving to the hospital. That patient does not qualify for TPA. The other thing you ask yourself is, does this person have any contraindication? Does this person have any contraindication? I go to my next whiteboard. There's a way I like to look at the contraindication for TPA for me, because you have to know the contraindication and you have to play around it. I use the mnemonic AID, AID. I think this one should make sense for you because US have stopped a lot of foreign aid to a lot of nations. So the aid is what I use. The A is for anticoagulation. It's for anticoagulation. Now, think about it. If TPA can worsen bleeding, it simply means that anybody that has problem with coagulation or is on anticoagulation, that person is not going to do very well with TPA because the person is going to have bleeding tendency. So somebody that is taking anticoagulation and the person have an INR that is greater than 1.7, this is a contraindication. Even though that person comes 2 hours, the person qualifies in time, but the INR disqualified the person from taking a TPA. If the person has a platelet count of less than 100K, it also disqualifies this person from taking a TPA. Straight up. That is the A part of it. Now, the I part of it is ischemia. This is ischemia. If this person have some ischemic condition like stroke, MI, and TIE, especially within the past 6 months, this person is not qualified to take TPA, even though the person qualifies in time. This rules TPA out for the person. Now, the D is disease. Hypertension is one of them. Not just all hypertension. Oh. The blood pressure has to be above 185, 110. 185 over 110. Then, this guy also has uncontrolled DM with sugar above 400. If the DM is uncontrolled, sugar above 400 is also going to be a contraindication. But now, I want you to be very smart. Let us play around with this thing. So let us assume that your patient came in to the hospital 3 hours to the onset of the symptoms of stroke. You assess the patient, glycocoma scale is like 12. The patient has good oxygen saturation. You quickly went and did a non-contrast CT for the person. The non-contrast CT did not show anything hemorrhagic stroke. So this person qualifies for TPA. You now ask yourself, does this person have any of these And the answer is no, this person does not have any of this. What is going to be the next best step? It's going to be TPA administration. Now, let us assume that that same question, that person in question came 3 hours to the onset of stroke. The person has a good glycoma scale. Oxygen saturation is good. You went and did non-contrast CT. The person has no form of hemorrhagic stroke, so you suspect ischemic stroke. But the person has a blood pressure of 200, 120. What is going to be your best next step? Your best next step will not be to give TPA. Your best next step will be, I need to lower this blood pressure to less than 185. Oh, shit. My system is going to go off. So we're going to end in about 5 minutes. Basically, where I stay currently, I'm not permitted to use gen, and I don't know why they turn off the exit lights. So if you look at this, your best next step is going to be that you will first of all lower this hypertension to less than one. It was 200, 120. You have to bring it to less than 185, 110 before you now give the person TPA. You see how this step two goes. Next best step is the king. For everything you do, you have to be able to pick it out and say, because of this thing, he does not qualify for this thing that would have been the original next best step. Because of this blood pressure of 200, 120, I cannot give TPA at this time. My next best step is to give him labetalol, nicardipine. I need to slowly bring down this blood pressure. Then I can push my TPA. Men and brethren, sorry I cannot use Gen on this current estate. This is where we'll likely have to put a pause to this class, but no worries. In our next section, we're going to complete this. I've already tied in the most important thing. We just have a little thing to play with. So I will complete this in the next section, and then we can proceed to do OBGYN still in the next section. We'll still have the U word, we'll settle it in the next section. So this is where I'll have to log off, and I'll say good night to everybody.
Thank you.